Hello there. Happy Monday. I got a great email question from a fellow physical therapist, so I'm so excited to talk to you all about this today. By the way, if you haven't met, my name is Julie Hirschberg. I am a neurologic physical therapist and the owner, founder of Re+active Therapy and Wellness, where we run an integrated program for dystonia. I wish I had our dystonia program director here, Lincoln. He's amazing. And I've learned so much from working with our team on dystonia. But I think the folks that asked this question, the person she asked it for, they're here. So I am so excited to chat about runner's dystonia today. It's interesting because I get questions quite a bit about different types of dystonia, runner's dystonia being one of them, and it's actually not that common, but I've seen quite a few cases. But again, we specialize in dystonia, so this is what we see. Runner's dystonia is not the most common dystonia. Cervical dystonia is, which we do see a lot of. And there's a lot of reasons why a person might have dystonia. But when you see it in running, like you might see in a musician, or seeing somebody that uses their hands a lot, like a musician's dystonia, a writer's dystonia, artist dystonia, these are in highly practiced task-specific dystonia. And I think that's really important to note that this is not talking about a Parkinsonian dystonia or a genetic dystonia. These are task-specific dystonias, meaning they develop within a particular task. And in the terms of runner's dystonia, it's in running. It's not really surprising to me. I'm a runner. It's not surprising to me that a person might develop runner's dystonia because it's a highly repetitive task. And if you're a runner, especially, I'm not an elite runner, not competitive, but when you're a runner, you're like, you gotta run and you gotta do it. And you do it sometimes through injuries. You do it very repetitively, sometimes without a lot of variability. And those things can kind of predispose to developing a task-specific dystonia. So thank you for this great therapist for emailing me this question so that we could all talk about dystonia and learn together. So let's talk first about the typical patterns that we see in runner's dystonia. Most often it's in the foot. Most often we see plantar flexion and inversion, so a down and in of the foot during running, but it can occur with a pattern at the knee and the hip as well, sometimes the whole leg involved. And sometimes it can be in running, but then also walking or other tasks as well. One of the things that I think is really important is to understand that runner's dystonia is not a purely biomechanical issue, but biomechanical pieces can be contributing. So this brings me to the first image we need, which is the pie chart. So we do have a dystonia pie chart. And if you've heard me talk before, these are the main key areas that we talk about in a lot of different neurological disorders. And I'm gonna talk about them in runner's dystonia specifically. So there are issues of motor control in runner's dystonia, and frankly, any dystonia. Motor control, sensory issues, I'll go around the pie. So at the top is motor control. The next is sensory. The one at the bottom right is psychosocial. Left is lifestyle, autonomic, and then physical limitations. Typically, where a physical therapist starts in runner's dystonia is at the physical limitations. We're looking at those biomechanical pieces, strength differences, nerve dynamics in the lower limb. These I often see impaired in dystonia. Those are all extremely important. They're not usually the cause of the dystonia. They're often secondary to the dystonia. Maybe potentially an injury, a strength deficit or difference, a sensory difference could have contributed to an abnormal pattern that drove the dystonia in the first place, but not all of the time. So that's that top box, the physical limitations. We want to pay attention to them. This is the bread and butter of what physical therapists do. But to be honest, it's the smallest part of dystonia treatment. The areas that I see that are most often overlooked when I meet somebody with dystonia are the interactions between the motor control, sensory, and autonomic. And I'll hit on the lifestyle, psychosocial pieces too, but those big three pieces of the pie. On this diagram, they're like the lime green, Kelly green, and dark green colors. I want to just give a couple of thoughts and ideas about each of these. But the caveat here is you have to assess all of the pieces of the pie and put the pieces together. My experience is that treating one piece individually doesn't usually work. It can provide some improvement and some benefit, but it's really how these pieces integrate together. And that is because we do understand dystonia and runner's dystonia as a disorder of connection in the brain, sensory motor feedback loops, neuroplasticity gone awry. So let's start at the top with the motor control piece and some of the pieces that we will look at changing to try to unlock some non-dystonic automatic movements in people is really looking at changing things like the posture or the movement itself. Some of my favorite things are to do things totally like you would never do them. So a great example is, we've worked with a lot of musicians, is to put them upside down playing their instrument. The dystonia usually goes away, and it tells you a lot about the postural influence and positioning on that person's dystonia. Well, we can do the same in running. And many people have heard, I think there was like a person in the news who could run, but could only run backwards. Well, that is not very practical, but it is certainly worthwhile to try. So usually what I'll look at for people is changing the direction, the speed. So I know, for example, I run really well at a particular cadence, as do a lot of runners, and they even train at that. Well, sometimes it's actually that lack of variability in the training that can lead to or cause the runner's dystonia. So playing around with different cadences, and different parameters in the running. So heel strike, mid-foot strike, toe strike, playing around with those pieces to change up the variability of input can be really helpful. I want to respond. There was a comment here. Somebody said, I wish my team of providers would get on one page, like you said, to put all the pieces of the puzzle. But now it's just this provider and then a referral for that. Yes, exactly. That's exactly why we have a team approach to dystonia and many other disorders, is because it is quite frustrating to have to try to put all those puzzle pieces together. So this being one of the biggest puzzle pieces, which is the motor control. So some of the things that can influence the motor control, like I said, the direction, the speed, the cadence of the running, the environment for which you're running. So whether that's treadmill, whether it's hills, I really love to introduce different types of surfaces the person doesn't run on. So sand, grass, gravel, wood chips, all of those environmental pieces can make a nice change for the person. Mirror training and graded motor imagery can be a really great part of motor control training as well. Love, love, love using that in dystonia. So graded motor imagery is something that we typically do. The science behind it, the evidence there is in pain, but it is very, very applicable to dystonia. So that would be another piece that can be helpful. I also like using biofeedback. So we use a simple surface EMG biofeedback. doesn't work to get the tibialis posterior, which is one of the typical muscles implicated in a runner's dystonia. But I like to put it side to side and look at activity of some of the more superficial muscles like the gastroc and the plantar flexors, and look side to side for differences. And if there is some overactivity in the plantar flexors, then what I do is look at that in all of these different postures and positions. Depending on the runner's dystonia, sometimes all the person needs to do is think of the dystonic posture and the muscle tension starts to rise. And so if we know that, we will actually work on that piece initially. Okay. That was a lot of pieces in the motor control pie. Let's go into the sensory pie. This is a huge one that I think is overlooked. It's not tested as much, I think, as the motor control piece. And honestly, I didn't learn any of this stuff as a physical therapist. This is stuff I really have discovered in dystonia, which, by the way, dystonia guru and master who I've learned so much from is Dr. Nancy Beal. She has done a lot of the research at University of California, San Francisco. And my first dive into this was when I opened my practice and I went to one of her courses. So she taught me a lot of what I know about dystonia, and I love her research. The sensory system is one of those that she really talked about. And you can see like how big this piece of the pie is because there's so much that you can look at here. So beyond just, is the light touch impaired? Is vibration impaired? You really want to look at how is that person's foot, in the case of runner's dystonia, if it's in the foot. Again, some people have it involved of the knee and the hip. If it's in the foot, I like to think of what does the sensory map of their foot look like? And the way we can test that is through looking at localization and discrimination along the ankle, foot, calf. I usually hone in on the area where the person feels it's gone awry, or the first place that I really see the movement initiate from. Now, in runner's dystonia, what this does involve is I will do a high-speed motion capture running analysis. And I actually know that the person who asked me this question runs a lab to do this. So amazing. What I look for is where I see that first movement gone awry. And a lot of times it's happening kind of just before toe off in the running cycle. And so I'll look for that, and I will look to see where I see that movement coming from. And I will start assessing, is that at the ankle? Do I see some unusual things at the toe? So yeah, we'll do some things barefoot. Do I see some unusual things further up at the calf, or maybe even the knee or hip? And that is where I want to assess first. I never throw in sensory treatment without assessing. I will assess first and then incorporate that into treatment, whether that's like a discrimination treatment or a tactile localization treatment. Maybe it's joint position error, kinesthesia. Maybe it's applying compression. One of the famous stories I've told of one of the first people that I saw with runner's dystonia was actually, she thought it was her foot, but it was actually her knee and the hip that were the issue. And we found an area along her hamstring where that localization was really impaired. It was like she was getting the wrong information about where her knee and hip were in space, which you can imagine would cause your knee and hip to do unusual movements like you see in runner's dystonia. And what we ended up doing, and honestly, I don't know why exactly this was the thing, but because we ended up with a stuffed animal it was a very small stuffed animal strapped around her hamstring, and it gave just the right information. I think it was the length, the weight, the location of the stuffed animal. This is not called stuffed animal therapy by any means, but it was all of those factors together, and it was that she could run without dystonia. And if you're a runner, you don't want to keep running with the dystonia. It just reinforces the pattern. So one of the key pieces with your therapy team is to find that way that you can run without the dystonia. For her, it was a sensory piece, and she could run without that. She started really short distances. She didn't even care because she wanted to keep running, and she ran with that little stuffed animal until we could train some of these other pieces. So we could actually train that sensory. What I think of is the homunculus. So the way our foot and leg and hip are organized in their brain. I'm like pointing here because this is right where the sensory cortex is. What has been found in dystonia and task-specific dystonias and runner's dystonia is that area of the dystonic limb is kind of smudged. Like there's not a clear picture of it in the brain, which may be causing those abnormal contractions. So what we want to do is discover what that picture is and then train it. Some of the latest things that I really love for this, we've always used tens along the dystonic muscle or other sensory things as well. There is a new little device. Oh my gosh, what is it called? It's a HyperIce device. And I know it starts with a V, and I want to call it the Viper. And now I don't know if that's the case. My goodness. Well, I'm not a spokesperson, obviously, for this company. But what I love about it is you can actually stick it on kind of like a TENS, and you can change the level of vibration over a muscle or a body part. It also does heat. And we've been playing around with that in dystonia and in runner's dystonia and really liking that because it changes the sensory information. So I'm going to have to try to remember what the name of it is. I can't believe I'm drawing a blank on that right now. But we've been liking using that. But the brand is HyperIce. And that can be part of the sensory treatment. Okay, so that's a big part. You really want to assess in your runner with dystonia, what is the picture in their brain of their leg? Oh, one more piece, because this goes along, these are artificially pieced out in pieces of pie, right? Like obviously the sensory component interacts with the motor control component. It's hard to actually tease those apart. But using graded motor imagery and understanding sensory perception, I love using the Recognize app. It's from the NOI group, but it's really great for feet and knees too. So you can look at basically and assess through a series of pictures, can you determine right and left? So it helps you with that sensory discrimination. What I have found in runner's dystonia is either people are impaired with that or they're really, really good. And this is one of the things that we kind of see in dystonia is that person that has that really like quick, fast, super bright, smart, fine-tuned brain. It's almost like that neuroplasticity can go awry even quicker because they learn things so fast. Their brain learns things so fast. Now, the good news is that same characteristic of your brain that kind of might have contributed to the dystonia can also be that part that can make it get better, can cause neuroplasticity to go in the positive direction. So somebody asked me the question, actually, can this be fully recovered? Yes, it can. Absolutely. And there are all of these pieces go into this. I do not believe in a one size fits all, like, oh, everybody, if they try this brace or try this light therapy or even try this vibration. No, I have never seen that. I think it takes a very individualized approach. I want to go around up to that like darker green autonomic piece. So this is a piece that even I, when I was early on in my days of reactive and in runner's dystonia, did not fully understand how to assess and then treat any autonomic components of dystonia. And it's honestly like, wow, I really missed the boat here early on. And then now I don't, but I did, because we do understand in the task-specific dystonias, Runner's dystonia, somewhat even more so in the musician's dystonias, that they often occur, the onset is during a very high stress. Stress, we know, is high cortisol, high autonomic, sympathetic activation activity. So in musician's dystonia, for example, a audition or a presentation of a big piece. The same thing can happen in runner's dystonia, is that the onset can occur under a high stress situation. It doesn't mean it's psychological. It does mean that the stress system and the impact on our overall nervous system can cause some of this neuroplasticity to go awry. And so it's important to actually bring that into treatment, assessing it. So we use heart rate variability a lot in our assessments because it gives a direct kind of bird's eye view into the autonomic nervous system. And then we can use that directly in treatment as well. So one of the things that I did even before I had a good heart rate variability monitor, by the way, we use the LIEF, L-I-E-F, not associated with them either. It's just my favorite one. It's a portable EKG that you can stick right on the skin and hook up to your phone, and it can give you feedback. It takes you through biofeedback activities when your heart rate variability drops. Find it really helpful. But if you don't have that, what I used to do is really look at the dystonia and look at it in the task. So we might be running, and then I'd add an autonomic activity to that. So I might add an extended exhale and see if it changes the dystonia. I might add weighting or grounding or compression and see if it changes the dystonia in the moment. So that's not necessarily giving me a direct measure of the autonomic. And so now I like to use the LIEF as that more direct measure, but then I'll add on these things and see if the dystonia is responsive to an autonomic input. Most people that I meet with dystonia are absolutely like, yes, if I'm stressed more, if I've had less sleep, this kind of moves us onto the lifestyle piece or the psychosocial piece. Yes, it gets worse. Well, no kidding, because we do understand dystonia as a increased excitability in the nervous system. And so when we have increased levels of stress or cortisol, by the way, these could be physical stressors, they could be mental stressors, anything like that. It could be a virus, right? Any of those things can change that immune and hormonal response, and the dystonia can increase. So lifestyle. Now, I want to point out a couple of pieces. I couldn't hop on here without a little bit of evidence. There's no large randomized controlled trials in runner's dystonia. In really any dystonia, there's not, because it's pretty rare. So it's very helpful to go to what we do know. And this is one of my favorite articles from Nancy Beal and colleagues, and it's from 2008. It's not a new one, but I go back to it again and again. It's actually how we put together our integrated program is based on some of this research. So they worked with people with focal hand dystonia. I know it's not runner's dystonia, but a very similar mechanism of repetitive task-specific dystonia. They did a program. Their program was two weeks, and it was all-encompassing. It's really where, I'm going to come back, it's really where the pie chart comes from. So when I hit on key pieces, they did motor control training, sensory training, and a huge dose of lifestyle. They focused on sleep, the person getting eight hours of sleep. They focused on regular meals. I know that seems very, very basic, but these things are really important when it comes to brain health. So regular meals every day, exercise. Now, if you're a runner like I am, you're going, well, I can't run. And that's my exercise. Now, certainly if you're an elite runner, you've been through your share of injuries. I had a stress fracture this last marathon I was training for, and I had to go through cross training. Hated it. All I wanted to do was run, but did it. So exercise is so important for nervous system modulation. And when your main source of exercise, maybe even your main source of stress relief, is running, this becomes really, really hard. And so this is where I love our team. Our OTs are huge lifestyle intervention folks. Really work with somebody to maintain their level of exercise and fitness outside of running, if it needs to be. If we weren't able to find the special teddy bear technique for that person to continue running, we need to explore other things. So this was all part of the study: is regular exercise, sleep, diet, hydration. All of those pieces were important to the dystonia recovery. In this article by Bale and colleagues, they had a high percentage of people who were able to return fully to their activity, which is huge in dystonia. Another thing that we talk to, again, looking at this psychosocial and lifestyle pieces of the pie in dystonia, is we talk a lot about variability. Most people with a task-specific dystonia got it because they had I'm not saying this was the cause of it. They do a task that is not as variable. So running can be very repetitive. If you're a high-level musician, very repetitive. So a big part of what we focus on in treatment is introducing variability into the running, into the day. I love to run in the morning. It's super helpful to run at different times of the day. And think about the nervous system. If there's a rut that has been made, its neuroplasticity gone awry, and you're consistently getting dystonia, you need to do all of the things to undo that rut and create new pathways. So different times of the day, different running paths. I mentioned different speeds, different cadences, different running gear, different shoes, different directions, different, I've been really into a fartlek run, which is like a lot of differing paces, right? So all of those pieces are really important. And what our OTs do a lot of is not just introducing that variability into the running, but variability in the day in general. I'm like the perfect candidate for getting dystonia, to be honest. I'm pretty, I like a routine. I like to almost eat like some of the same things every day. These are some of the pieces that are actually really important for the undoing of dystonia, is adding that variability, even to things that seem to be not related to dystonia. So variability in the day overall, very, very important. One of the things that I really want to emphasize here, and by the way, if you are not already on our newsletter, if you're a clinician and checking us out, thank you. By the way, thank you for caring about dystonia. I think people, when this person sent me this email, I was like, yes, you can help this person with dystonia. I think people with dystonia need access to care with experts all over the world. So please share this and join our newsletter if you're a clinician at reactiveeducation.com. I'll send out links to all of these. If you are a patient, join at reactivept.com. I send out a newsletter every Monday, so I'll send it out next Monday with links to articles. I did a full Lit Search update on runner's dystonia with this question because it's been like a year and I wanted to go, is anything new? So I'll put those links in the newsletter this week. It will come out on Friday. And as Roberta says, we definitely need access to care. I agree. That's why I hop in here on every week. That's why my passion is educating and learning with other therapists, because I think every city should have somebody who understands runner's dystonia. Now we're one step closer. So I hope that was helpful. Please send me, if you have more questions on dystonia, send me questions. I'd love to hear from you all. And thank you. Thanks so much for joining me today. And I just appreciate our little online community too. Yes, and Mother Runner Bree says, great to have PT providers who have conviction and care plan and a path forward. I will tell you, Mother Runner Bree, as a runner, this is not the end of your story. You will be running, and anybody with runner's dystonia, you will be running dystonia free. It is not a lifelong sentence. People get better, and you will get better, and I have great hope in that. We see it all of the time. So I'm excited to hear how things go. Keep me posted. Thank you so much for asking great questions and for being a community that cares to learn and grow and get curious about this stuff. I appreciate it so much. Have a good night.